Good evening, everyone, and thank you for joining us for tonight's webinar. I'm Dr. Meg Green, one of the technical services veterinarians for Contura Vet, and we're delighted to have you join us tonight, which promises to be an informative and engaging session dedicated to advancing equine veterinary care with particular focus on managing equine osteoarthritis. It is our distinct honor to introduce to you two of the most respected voices in the field of equine sports medicine. These veterinarians bring decades of combined experience, a deep commitment to equine health, and a passion for education and innovation. Our first speaker tonight is Dr. Sarah Lejeune. Dr. Lejeune is a member of the American College of Veterinary Sports Medicine and Rehabilitation, which focuses on the diagnosis and treatment and lameness of various performance-related musculoskeletal injuries by an integrative approach, including acupuncture and chiropractics. She is the chief of the Equine Integrative Sports Medicine Service at UC Davis. And Dr. Sarah Lejeune is also a board-certified equine surgeon and has been a member of the UC Davis Equine Surgery faculty since 2003. She is certified in veterinary acupuncture and extensive acupuncture training from Colorado State University, as well as the Chi Institute in Florida. She also obtained her veterinary certification in chiropractics from the International Veterinary Chiropractic Association and is certified in veterinary thermographic imaging. Joining Dr. Lejeune is a fellow leader in equine sports medicine, Dr. Ron Gaeta. Dr. Ron Gaeta graduated from the College of Veterinary Medicine, North Carolina State University, accumulating multiple awards, including top of his spot in his class in equine medicine and surgery. Following graduation, he joined Turnpike Animal Hospital, the predecessor to Fairfield Equine Associates, where he was a partner for 13 years before establishing Dunbarton Equine in 2003 until 2024. Dr. Gaeta has recently rejoined Fairfield Equine, where he continues to practice advanced equine medicine, delivering expert care and high-quality performance equine athletes. Dr. Gaeta is a past member of the Board of Directors for the Northeast Association of Equine Practitioners and the Connecticut Veterinary Medical Association, a member of the American Association of Equine Practitioners, an American Medical Association member, a Veterinary Medical Association member, the United States Equestrian Federation, the United States Hunter Jumper Association, the International Veterinary Acupuncture Society, the International Society of Equine Locomotor Pathology, and Connecticut Veterinary Medical Association, and is also an official level 3 FEI veterinarian as well as an FEI permitted treating veterinarian. In addition to these two speakers, I would like to introduce you to Dr. J.D. Conway, the Director of Veterinary Services here at Contura Vet, who will be assisting me tonight with moderating the Q&A portion of the webinar this evening. If you have any questions throughout the presentation, I would ask that you please put your questions into the Q&A box at the bottom of your screen, and that we can address your questions at the end of tonight's presentation. Whether you're a seasoned practitioner or just beginning your journey as an equine care practitioner, this is a rare opportunity for you to be able to learn from two of the very best in the industry. Please join me in giving me a warm welcome to both of our distinguished presenters this evening. Dr. Lejeune, I'm going to turn it over to you.
Thank you so much. Good evening, everyone, or afternoon, depending on where you are. Thank you for this warm introduction. And anyway, I'm very honored to be here today to share some experiences about how I use Arthramid in sport horses. We can skip to the next slide. So I just want to say, and I think that all of us who deal with sport horses and lameness, you know, that we have lots of tools in our toolbox, because obviously, you know, the best and more successful approach is the multimodal therapeutic approach. So obviously we have lots of tools in our toolbox. We're obviously focusing on Arthramid and polyacrylamides, but you'll see from, I think, Dr. Gaeta's cases and myself that we're doing more than just intra-articular injections, you know, that we're mostly doing, you know, that plus combination therapy. And then afterwards, of course, in my world, I'm really focusing on the physical rehabilitation and strengthening and training of these horses. Next slide, please. So one of the most common areas that I'm currently using Arthramid in is a joint that I think all of us commonly treat, and those are the lower hock joints. So in this case, this is a 9-year-old warm blood hunter with bilateral hind limb stiffness, positive to spavin flexion tests. In the past, this would be a horse that I would have just injected methylprednisolone in. But over the last year and a half, I've been adding 0.5 ml of Arthramid in addition to the 40 milligrams of methylpred into the tarsometatarsal joints. And though I don't have an actual case series, it seems that this practice has extended the need for repeat injections. So I'm certainly going to stick with that because that seems to be working well. But I'll be interested at the end of this to hear what Dr. Gaeta does in those types of cases. Next case, please. So those of you who know me know that I love axial skeleton cases, so of course I have to present one. This is an 11-year-old warm blood gelding. He historically competed in dressage at a high level, but then sold to the current owner as a hunter. On his pre-purchase exam, there were really minimal, clinically significant findings, but his walk was lateral, which, you'll see here in a second why that's important. So he did show successfully in the Hunters in Wellington during the 2022-23 season, but he developed this intermittent, obscure hopping-like lameness of the left front, which was kind of ignored initially because it didn't seem to affect his performance. But then by August, they noticed that he was really resistant to backing up and that he was intermittently tripping and that he wasn't going forward. So he was evaluated and he was in fact a grade 2 out of 5 ataxic with proprioceptive deficits in all 4 limbs, worse in the hinds. He was definitely resistant to backing up. And in terms of, the static exam, he was symmetrically muscled, had a good top line, but he definitely had symmetrical mild caudal cervical atrophy and then a intermittent inconsistent right hind lameness. His radiographs of the cervical spine, which I'll show you in a second here, were not super exciting. And, that's obviously a challenging area that we're dealing with in terms of correlating, clinical findings with imaging findings. We did do EPM, serum titers, Lyme titers, full blood work, urinalysis, trace minerals, all of that was within normal limits. So the client obviously had stopped riding the horse and started just lunging and doing some strengthening training in the Pro 6 lunging system. But he progressively got worse and was showing some facial grimacing indicative of pain. His neuro exam by then had progressed, where after forced neck extension, he was now grade 3 out of 5 ataxic, and definitely had some signs of discomfort, more tail swishing, more facial grimace, etc. So at that point, we decided to refer him for a CT myelogram. Now we're lucky at UC Davis. We have a brand new amazing imaging center, so we can do all this ourselves. But at the time, he was referred to Almo Pintado. So next slide. So this is just the x-rays that we had taken originally. So you can see 5, 6, 6, 7, 6, 7 T1. And I mean, nothing's super exciting, which, welcome to the world of sport horses. I think we see enlarged C6-7 articular process joints quite commonly in these horses. There was this mild kyphosis at C5-6 in neutral, but it resolved in an extended position, so probably not super significant. And then he had this small osseous protuberance at the ventral aspect of C7, but again, we didn't read too much into it, so he did end up going for a CT myelogram. Next slide, please. There was no evidence of spinal cord compression in neutral. Of course, flexed and extended views are not always able to be done and were not able to be done. He did, however, show moderate OA of C4, 5, 6, 7, and then some very mild foraminal narrowing at C4, 5, and C6, 7. So with those findings, we decided to, of course, pursue treatment and talked about some options. Obviously, this is what we do also in sport horses quite a bit, cervical articular process joint injections, ultrasound guided. And we did go ahead and do that on this horse. We injected 5, 6, and 6, 7 bilaterally. And initially, this horse was treated with just triamcinolone in each joint. But then when he came back up here to Northern California, we retreated him with 6 mg of betamethasone, half a mil of Arthramid, and a titch of amikacin per each one of these joints, just so we could sleep at night. And we did inject the right and left side here. Next slide. Just want to reiterate that, in terms of this injection technique, I mean, I think most of us are pretty comfortable with this, but we have to remember that the joint capsule extends beyond the joint margin. So when you're inserting the needle ultrasound guided, it's actually a pretty large target. And that, the joint distension, it can extend axially and cause spinal cord compression. And Natasha Werpy has actually shared some pretty incredible images of MRI that she's done post-mortem, where the actual synovial outpouching is going even into the spinal canal and across to the other side on some of the specimens that she's looked at. So, this distension of the joint can itself, obviously, you could imagine, cause spinal cord compression. We know, of course, that the joint margins are part of the boundary, or one boundary of the intervertebral foramen. And so that, any kind of joint distension can also potentially compress the spinal nerves. And so, that's also a consideration not only for the clinical signs, but for the treatment, because you don't want to be injecting too large of a volume, because of course, then you could be causing a lot of distension, which could then, inadvertently cause compression of either the spinal cord or the spinal nerve. So just a little FYI of why I think it's really important that we maintain a low volume. Next slide, please. So after after we treated this horse's neck, so with intrasynovial injections, we did a whole slew of other modalities to address, inflammation and pain. So therapeutic laser, shock wave. He had acupuncture, lots of range of motion, and postural rehabilitation with our carrot stretches. We use balance pads, this Pro 6 system that he's actually wearing right there is really nice for proprioceptive rehabilitation. And then he actually didn't end up going to the aqua treadmill, but if you have one, that's also a very useful tool that can be used for these types of cases. I, of course, threw in some chiropractic as well. And then over time, as he became stronger and less ataxic, we started doing some pole work and cavaletti work in hand initially. And then again, as he became stronger and less ataxic, we started some ridden exercises, initially, focusing on a lot of transitions within the gait and between gaits, and then incorporating, again, poles, cavalettis, things like that. But I'm going to emphasize that when you're rehabbing a horse like this, it's really important to have a very skilled rider, because the head and neck position and the capacity of this horse to get into this positive tension where they're working over their back and neck is really critical for them to develop the proper neuromuscular pathways. Next slide, please. And this horse actually, after sort of had between the initial diagnosis the treatment and the rehab. He went back successfully to competing as a hunter, and he is actually doing quite well this year with his rider, and I think they're going to McClay finals. So that's very cool. And I have re-injected his neck once since, again with that protocol of 6 milligrams of betamethasone and 0.5 ml of Arthramid per joint. Next slide, please. All right, so moving on to another type of case that I think Arthramid can be quite useful for, and that's in the cases of effusion of the deep flexor tendon sheath. And so in this case, we had a 14-year-old warm blood gelding jumper with severe effusion and a mild lameness. So it was really so intermittent that we really didn't go ahead and block this. We went right to ultrasound, and you could see the images here. We had moderate anechoic digital sheath effusion with mild synovial proliferation. We did not see any obvious evidence of other flexor tendon injuries, though, of course, we're always worried about those longitudinal tears that we're not going to see. So, those do make me nervous to ignore. So, we talked about potentially doing other diagnostics, but the owner was willing to try treatment, particularly because the horse was not very lame. So we did inject this horse with Arthramid and PRP and maintained reduced activity for a couple weeks, and the lameness and the digital sheath effusion resolved and have stayed gone for over a year now. So I think that was a very successful case. I'm going to contrast that with the next case, please. So the next case is sort of presented the same way. So again, a warm blood event horse with digital sheath effusion, but this one is now pretty lame and positive to flexion. And this one did have a manica flexoria tear. And in my hands, these need to go to surgery. Just treating them medically doesn't always get you, the successful outcome, but we do, I do treat them with PRP and Arthramid after surgery. And that seems to be, a good way to prevent adhesions, decrease inflammation, and get them back to work. Next slide, please. And then another case, so a 9-year-old warm blood imported for dressage. This horse was perfect for a couple months and then was acutely 4 out of 5 lame. He did have mild improvement with a PD block, and then a almost complete improvement of the lameness with a nabaxial sesamoid nerve block. So we radiographed the digit and the fetlock, and there were absolutely nothing that we could hang our hat on for this. So next slide, please. He did, of course, go into the PET scan. This would be, because we were definitely worried about more problems. He also had an MRI. And we did find a significant lesion or area of uptake in proximal P1, as you can see here on these 3 images. Next slide, please. And here on the MRI overlay, you can see actually that he has a subchondral lesion in proximal P1, which we don't love to see those types of lesions because, next slide, please. So this horse had, we threw the kitchen sink at him, obviously he was rested. We definitely gave him quite a few doses of clodronate. We shock waved the area. He had multiple intra-articular injections of Arthramid and PRP within that fetlock to help with any synovial inflammation that he could have. And there's absolutely no improvement, unfortunately, even after a year. So that was not super successful, but not super surprising, I guess, with that level of subchondral injury. So this is a type of case that I think you know, is probably not going to be successful with just intra-articular therapies. I think that's what I've got. And I'll turn it over to Ron.
Okay, thank you. Appreciate being here tonight and having the opportunity to talk to you all. I would say just briefly before, I think most of the cases I use Arthramid in, we don't do a lot of advanced diagnostics. It's day-to-day, treating coffin joints, fetlocks, et cetera, and blocking and lameness exams. But a lot of them, as these cases, do go for advanced diagnostics. And I love your Venn diagram, because the last one I've got, it seems like a lot of them really are multimodal. Almost all of them, I would say. But so we'll start with this guy, Igor. He was a jumper that belonged to a client of mine. He was out on lease. He was doing -30s, -40s, doing quite well. And then they called and said, oh, he's lame. We want to send him back. Well, he came back and his feet were terrible. I don't know what they did with him, but he had no heel. Palmar angles were flat to negative. He was quite lame on the left fore. Just jogging in hand, 3 out of 5. So did a bunch of blocks, palmar, digital, he's slightly better. A back seal came sound, went back next day, blocked the coffin joint directly intra-articularly, and he was about 50% better, not sound. So within a back seal, then he was sound. So he came in and had an MR. If you go to the next one. So the picture to the left, he just had a degree pad on. When we took the shoe off for the MR, you can see it's pretty flat, and there was just no heel, no foot there at all. Nothing with hoof testers, remarkably, as lame as this horse was. You can go to the next one, please. So this is his MR. He had a really bad synovitis, arthropathy in that coffin joint. On the stir, on the left image, you can see the arrow that points up from the bottom of the image. That's impar ligament inflammation. Those horses seem to be, at least the ones we see, they're really lame when they have that. He also had some bursitis as well. So if you go to the next slide. So first I treated this horse with Prostride, both the bursa and the coffin joint. A farrier friend of mine came and helped us with it, and he came up with this crazy modified spider plate with impression material. And we wanted to get his angle better, but not put a ton of pressure up through the frog, because he had a bursitis, and we're going to make that worse. He did get treated at OSFOS. Some people might think it's too soon, but I retreated him at 30 days as well with the OSFOS. If we go to the next one. So a week afterwards, came back and put Arthramid in a full syringe in his coffin joint and a 0.5 cc in the bursa. For some reason, the horses that I've treated bursas, when I've used the entire syringe, I've made some of them lame for a while. And I just wonder if it's like putting a pebble in their shoe is just too much. And with a 0.5 ml, I haven't had that problem. Then we did come back and retreat at 6 weeks, both the bursa and the coffin joint. Gave him 4 weeks off, just hand walk, tack walk him for 4 weeks, and brought him back into work. He's been doing fantastic. We're a year out. He's back in California. Actually, we're longer than a year. This is September. So it's about a year and a half now. He lives in California. He's doing the -40s, -45s out there. They repeated the Arthramid in both bursa and coffin joint just about the 1 year mark. So I think it was like June-ish or something when this first happened. So he's done quite well with that. Okay, we can go to the next one. This is a tendon sheath. Actually, I almost used a case that was pretty identical to the one Dr. Lejeune used, with a hind digital flexor and also subcondylar revision in proximal P1. But I chose this one instead. It was sort of fun. So this guy, Peter, if you go to the next slide, he's just a low level eventer, 16 years old, middle-aged owner. She goes out and bombs around the weekends in these little level events and has fun. The horse, she wasn't sure what happened to him, but he had a lot of swelling in the distal radius and the carpus on the right fore. They, of course, as a lot of people do, treated it with Banamine and ice for a month or so. I can't remember exactly how long before they finally called and said, okay, it's not getting better. Can you come and see it? One of my associates saw it, saw a lot of fusion in that extensor tendon sheath and the carpus, enough that he physically couldn't bend his knee. Was painful when you tried to bend it. He just didn't want to do it. She did radiograph it. If we go to the next slide, there's just some periosteal reaction. You can see it maybe in that circle, but you can see how big the knee was. She chose to stay conservative, use topical surpass and ice. It was not successful. So if we go to the next one, the owner finally got frustrated, called me. I went and looked at it, and he was only about 1 out of 5 lame, but if you tried to flex that knee, he would just try to stand up and go over backwards. Radiograph was not unchanged, was basically unchanged. I'm sorry, unremarkable. If we go to the next slide, and I stuck the probe on him, and he had a ton of effusion in this extensor tendon sheath just above the carpus. And yeah, the extensor tendon didn't look great, but I think just with all the effusion, he was not a happy guy. So we can forward to the next slide. Did drain it that day and put Prostride in it, put a pressure bandage on it, let him sit for 10 days. I left the pressure bandage on for 48 hours, had him icing over top of it, then went back. It was smaller, but no matter what I've ever put in tendon sheaths, they always seem to come back. Bogs, the same thing. So I talked to her about trying Arthramid. I had used it in several bogs successfully already. So did the same thing, drained it, put Arthramid in it, pressure bandage, iced it, then tack walked. Okay, we go to the next one. When I went back to recheck him, now he's lame in both front feet. I was like, what the hell? So he couldn't care less about flexing his carpus right front. The sheath had stayed down beautifully. He's positive in distal limbs, blocked out in the heel. So I said, well, let's treat his coffin joints. So we just she's like, let's use the same stuff. So we did. We put Arthramid in him, gave him 5 days off, tack walk 2 days, which is typically what I do with coffin joints and Arthramid, and then put him back to work. And we can go to the next. It worked beautifully. We went back, rechecked him. He was back in work. The effusion in the tendon sheath had come back maybe 10%, 15%. It's never gotten bigger since then. We flatted him for a month. He stayed sound. He's beautiful. He's been great ever since. I gave him about a year and went back and treated his coffin joints, and he's back doing his low-level eventing, happy as can be, and that sheath has stayed down quite nicely. Okay, we go to the last one I had. So this is a true multimodal case. This was a horse that a friend of mine had treated. Was a client of his up here a couple summers ago, and she called and said it was still lame. So we can go to the next slide. I went and looked at it. It's an 11-year-old mare. She was doing the high amateurs at the time, and 10 days prior, she'd had her hock stifles coffin joints treated. Her comment to me was that no matter what they'd ever done to this horse, she always felt funny going to the right. And she figured, I don't know why, they always say it's got to be the shoulder, right shoulder. Well, so we blocked the left front. We can advance. And she was not very lame to the left, but she was quite lame, 3 out of 5 to the right. Flexions were not very exciting. I blocked up her leg, low palmar. I tried to get them just above the collateral cartilages. A low basi, actually should have put basisesmoid, but and 4-point nothing. Did a high 4-point, and she's sound. So like, oh, maybe she's got a suspensory. You could advance. Radiographed her leg, and like, I don't know, I don't know if that looked really unusual for an 11-year-old, but, and then ultrasounded it and it's like nothing. So we brought her in and, we have a hallmark and you can get really quite nice MRs. So we did that. We can advance. And she had a lot of really crazy stuff. So osteoarthritis in that metacarpal joint. The junction between MC2 and 3 was very inflamed. And then she had a lot of interosseous fluid in that proximal portion. You can see in the image all the way to the right, that arrow is pointing to the dark area in the cannon bone. If you advance, we pondered what to do with this for a bit. And then I decided, okay, she got done with ProStride in the carpus. OSFOS, which again, repeated in 30 days. Shockwaved her for once a week for 3 weeks. Then at 30 days out, put Arthramid in. She got quite comfortable in hand. We slowly brought her back to work over the next 3 months, just to let that interosseous fluid dissipate and that syndesmosis problem as well. So if you go to the next one. Oh, I thought we had one more on that one. So anyway, she came back into work. And by the end of August was doing quite well. So she was getting ready to ship to Florida and decided to retreat the carpus with Arthramid before she left. She went down and just flatted through the fall and then started showing again in January. So mid-January, they treated the carpus one more time with Arthramid, and she started at WEF the end of January in the high amateurs and showed every other week the entire season with no lameness at all. And has stayed quite sound. She's recently been backed off because the owner's got 2 other horses and the horse is getting a little older, but she's been treated once a year with Arthramid since then, just proactively, and has stayed quite sound. So those are the 3 that I had for tonight.
Excellent. Thank you very much, Dr. Gaeta and Dr. Lejeune, for those excellent case presentations and so much practicality in those cases. I think we've all kind of been there at times and wondered sort of what the next steps are. And, the imaging certainly makes a huge difference, as we all know. And so I think it's really important to think about that. But at this time, I'm going to turn it over to Dr. Conway, and he's going to assist with facilitating the Q&A session.
Sounds good, guys. A couple questions. So we're getting some questions that are coming in. One that came in earlier was this is directed more towards probably, well, both of you guys. Any reason to just do unilateral facet injections versus bilateral? Is it always bilateral for you, Sarah, or for Ron? Is that what's your thoughts there? That was one of the questions.
So for me, I rarely do unilateral. I don't think I've ever done it really, because when you think about unless there was like significant damage only to one side or very unilateral signs, but I think that when you think about how the spine is and, this is such a high motion area, sometimes even we know now from doing all these CTs on horses that have narrowing foraminal stenosis, that sometimes even the signs don't correlate, meaning they might have stenosis on one side, but then the lameness or whatever their clinical sign is on the other side. So it doesn't always correlate the way we want it to. We're still learning a lot. So for me, I always do them bilaterally. I don't know about you.
We do as well, because I've always wondered, is it you're stretching the joint capsule that makes it, or is it because you've got arthritic change and you're constricting the area? I don't know. The only thing I've ever done unilaterally was when we've injected around nerve roots that we thought were where you had stenosis. Otherwise, it's always bilateral. always do both sides.
Great, thanks guys for that. And kind of following up on doing cervical facet injections was, and this goes to a couple questions. How long after you inject, whether it's, I guess, facets or another joint, are you waiting to shockwave? Are you shockwaving the same day, doing it before, a couple days later? What does that look like, your shockwave protocol?
Yeah. So if I'm going to shockwave them, I mean, if they're really painful and my plan is to shockwave, I shockwave before I inject. And then I will shockwave them, whenever they need it later, a couple weeks or a week. But usually if I'm going to shockwave at the time of injection, I'll do it prior to the injection. And my typical protocol for really painful horses like this one, the one I presented was painful. He had 3 shockwave treatments at 10-day intervals. 1,000 shocks on each side of the neck, focused shocks. How about you, Ron?
Which probe are you using?
The big probe on the pulse vet.
The pulse set?
Yeah.
Okay. Yeah, sometimes I'll shockwave them first if I'm sort of on the fence. Is this really from the neck or not? Just to see the response. And oddly enough, I mean, you'll see a response pretty quickly in a lot of those horses, and then we'll inject them. I try to give them maybe 10 days or 2 weeks just because I want to see how well they responded to it. And then we'll shockwave them as necessary. I have quite a few that we will treat with injections, and then maybe 3-4 months out we shockwave them. They're good for another 3 or 4 months, and you can sort of string them along and keep them happy and just inject them once a year. So everyone's a little bit different, but if I think they need to be shockwaved, I'd do the same. I would do them first and then inject them. I've never injected one then shockwave right on top of it.
Thanks for that, guys. Next question is, when you're injecting Arthramid into coffin joints, what's your procedure? Sedation, abaxial blocks, etc.
Well, yes, I blocked them all of axial. When I first started doing this years ago, my mentors were like, no, we didn't even thought about blocking. We put a twitch on them. And after getting kneed in the face many times, I finally decided, well, maybe this would work better. And so I've always blocked them since then. I always put the Arthramid in first because most of the coffin joints are pretty effusive. And if typically I'll back up. So normally I'm doing Arthramid plus say PRP or A2, or more typically I like to use triamcinolone. It's just the way I was taught years ago and I've stuck with it. So if you I use the Arthramid first, and then even though I've tried to get as much fluid out of the joint as possible beforehand, it sort of plugs the needle up and doesn't leak out. And then I'll put whatever PRP, follow it with the more liquid portion afterwards, and then pull the needle out so I don't lose anything. Because when I first was doing it, say I'd put some triamcinolone in first, and it would try to push half of it out before I could get the Arthramid syringe on. So that's just the way I do it.
Interesting. Can I say how I do it? Because I do it differently.
Yeah, absolutely.
I mean, that's the part that's so interesting, is I think we all find our way, and it is sometimes the same and it's sometimes different. And so you got to just find what works for you. So I don't block them, and I do put a twitch on them. I do obviously sedate them. I like to give them all ACE before I start prepping them, and a small dose of ditomidine just to kind of chill them out. And then, top them up off with, ditomidine or xylazine or combination. I'm actually not using a lot of Torb because it's a pain, because it's a controlled drug. So I don't use it. But if I know a horse is going to be difficult, then I will use it. I do use a twitch, and I personally, actually, I encourage, the synovial effusion to leak out. So I place the needle and then I wait until I don't have any more fluid, coming out of the needle hub. And then I actually inject the liquid portion before I inject the Arthramid, but I like the other idea too. But I also, teach a lot of people how to inject, and I think sometimes they don't get a good feeling for how it feels to inject if it's Arthramid because it's so viscous. So anyway, I haven't lost a lot of volume because I usually inject, I leave that needle connected, and then I quickly switch out the needle, I'm sorry, the syringe, and put the Lure Lock Arthramid syringe on and chase it with that. So anyway, it seems to be working fine. I will say you don't want to, inject the Arthramid into a different syringe. I know early on we tried that once and we'll never do it again because you can't actually inject Arthramid through any other syringe, at least we can't. So you've got to use what they give you. Yeah, don't try to switch it out.
Yeah, that's good
Yeah, and
advice.
one other thing I'd throw in, I don't know, I would say since COVID, I don't know what happened to the manufacturers, but the needles now with the plastic hubs, I've blown the Arthramid syringe right off of those. When I go to push it in on some of them, they just don't seem, the quality doesn't seem to be there. My practice, they all like to use the plastic hub needles so they can see fluid, whatever. I have to fight tooth and nail to get the old aluminum ones because they screw on, they stay on really nicely. But I have had problems with some of the plastic hub needles, getting the syringe on nice and tight and having it stay on.
Next question, sort of related, I guess. If you end up blocking a joint with carbocaine, can you go that same day in with Arthramid, or do you guys go in that same day with Arthramid to that joint?
I guess you could. I don't like to do it. Um, I, I mean, typically those cases, they go to imaging anyway, advanced imaging. If I'm having to do an intra-articular block, I'm chasing something, so I'm probably not just gonna inject it that soon. So I typically try not to re-inject the same joint twice on the same day.
Yeah, I would
How about
agree.
you, Ron?
I would agree. And that's the way I was taught. That's like, if you block the joint, don't even think about sticking another needle in it for at least 48 hours. And I've just stayed with that. Plus, I would think if I've put carbocaine in a joint and then I'm going to put Arthramid or whatever, now I've really distended that joint. I don't like to do that. I think you just make the horse uncomfortable.
Agreed.
Next question here. When you discussed injecting the Manica, what are the volumes of Arthramid and PRP that you're injecting? And secondarily, are you injecting via ultrasound guided into the focal region of the tear, or are you injecting more peripherally around the tear?
Oh, I'm not injecting the manica per se. I'm injecting the flexor tendon sheath. So typically they have a fusion, and I mean, so I guess you could do it ultrasound guided, but it's pretty obvious where the landmarks are. So, um, it depends on, so those manica cases, typically they will go to surgery, have a annular ligament desmotomy, then we'll leave them alone for a couple weeks, and then we come back and inject them. With, usually I'll use, 3 mils of PRP, and then either one of 2 syringes of Arthramid, depending on how large of a horse it is and how much money the client has. I hate to say it, but Arthramid is expensive. So that is a determining factor. How about you, Ron?
I would agree. I like to use PRP in them. And then a couple, depending upon how big they are, a couple syringes of Arthramid. One of our surgeons likes to use polyglycan first after they've had surgery. I don't know, I've had great success with the Arthramid.
Do you,
So
Ron, do you send yours all for surgery, or do you?
no, not all of them. Like this recent case that we had that was like the one Sarah had presented, it had a huge digital sheath and flex lame, and he came, you know, he blocked it with a 4-point. So I said, I blocked the sheath directly just to try to figure out where it's coming from. And he was like 50% better. That one actually had a PET scan also, and he had subchondral lesion right in that central sulcus, but they decided not to they didn't think it was bad enough to put a screw in. So he got PRP in the fetlock and the sheath, and then I put Arthramid in the sheath, and he's just chilling, but we're 60 days out. That one actually is coming sound without doing anything else to him. So he just started tack walking this week.
Nice. Yeah, I just recently had a manica tear that I diagnosed on a horse here in Cody, and just used Arthramid. Actually put a little steroid first, bring down the effusion and make it a little bit more comfortable, and then went back with Arthramid about 5 or 7 days later. It's doing remarkably well. So I felt like some of them may respond without surgery, but I wasn't, being conservative on that one. And it wasn't a bad, really. I mean, it was just they're tears, but it wasn't horrible. It wasn't super effusive, but anyways. Next question is in regards to extensor tendon effusion over the tarsus. Have you ever used Arthramid in that region?
I have
Not yet, but I'm sure I will.
Yeah.
So,
Were you saying
Ron, do you find that those are clinically significant? I mean, we see them a lot.
No, it's because the owners don't like the look of it. And I try to tell them, I've never actually seen one lame from it. It's like, just leave it alone. I'm like, I don't want to look at it. So yeah, I would, if I was forced to do it, I would do it. I typically don't mess with them if I can.
I kind of feel the same. You go in there and you start playing with them, and then they get bigger, in my experience sometimes.
But I've had really good luck with huge bogs, with huge, a lot of tibiotarsal effusion.
Yeah.
And they'll come back a little bit, but nowhere near to the degree that they would with, and over the years, we've tried everything and atropine, you name it, and they always came back. And these have stayed down quite nicely. With typically I like a warm blood, I'll put 2 syringes in.
Here on, I guess this was Sarah, maybe. Case 1, when you said you re-injected the neck or injecting with the same Arthramid depot amikacin protocol, and what is the time frame that you inject a second time from first cervical injections?
So number one, no depot. I don't use depot in the neck ever, because I'm worried about soft tissue calcification. I know a lot of people do, and they think it's fine, but I don't do that. So so he had his first injection with triamcinolone, and then we re-injected him 2 months later with Beta Vet and Arthramid. And that was based on, persistence of some pain, some reduced range of motion, and still like a little bit of ataxia. So we were really trying to decrease the inflammation within those joints as much as possible.
Yeah, and I know of a horse about 1.5 years ago that was treated with Arthramid. I'm not sure why, but the veterinarian decided to use a full syringe per facet, as well as some steroid. And that horse was really bad for about 6 weeks. And now listening to what you were talking about, the distension, I never thought about that, but it took a while. It finally came around and was fine, but I don't know why they chose to put so much in there, because no matter what I inject, I don't use any more than about 1.5 cc per facet.
The next question is related to tendon sheaths, and they're trying to get their head wrapped around how an effusive tendon sheath could be brought down. I think maybe by Arthramid, or is it primarily the betamethasone doing the work to bring down the effusion? That's kind of what I'm gathering from the question. It's a little hard to read, but
Well,
Well, go ahead.
no, you go ahead. I think this is
Okay, I'll take that one. I think it's because of the way it's incorporated into the synovium, and the capsule gets more elastic. It gets incorporated into the synovium, and then you get a new lining. You have more synovial cells on the inside, and they're just seem to be producing more normal fluid, and they just stay down. Best thing I could say is like they're back under normal control, and I think that's the way it's working. At least that's my understanding at the moment. I think we're all going to learn maybe a little more at come AAP in December.
there you go. I can
Well-
tell you that from the synovial membrane is the nutrition center for the joint. So anytime you're improving that elasticity, like you mentioned, Ron, and softening that area, improving the architecture, downstream effect is going to be improvement of the synovial joint fluid, reduced inflammation, anti-inflammatory markers, and Dr. Pezzanite will present on that at AEP and ACVS, actually AEP and ICRS, sorry. So that's more to come there. And I think if I'm reading the question and I was to be, I'm not supposed to respond, I don't think, but I am. The beta is probably doing the work initially. Yes, betamethasone, I'm sure taking down some of the inflammation, but the long-term effect of why it's reduced for a significant period of time, I think is exactly what you were saying, Ron, due to the synovial membrane incorporation. So that's my understanding at least. And let me see if there's other questions here. I think that's it. One thing I was going to ask you guys both. Seems like you both had cases where you had areas of subchondral bone that was damaged, and you had advanced imaging. In the case that you presented, Sarah, didn't really respond necessarily to a lot of treatments or therapies, other than maybe shockwave or clodronate. And then Ron, you had one that it seemed to respond later. Maybe it was a significant time to Arthramid. Do you think that's kind of more typical? Let the subchondral bone heal and see what happens, and then come back with Arthramid, or any thoughts there on reasoning?
Well, I think in my case, there wasn't actually any synovial involved. I mean, like it was truly subchondral. So there wasn't actually any real fetlock synovitis or anything. So we were sort of preventatively, in a way, treating him in case that, I mean, we were just basically throwing the kitchen sink at this horse because it wasn't responding. But I think there's other cases where certainly there is synovial involvement, that subchondral bone plate is damaged. And so now you do have inflammation within that synovial compartment. And I think in those cases, certainly Arthramid or any other intra-articular therapies could be more effective.
Yeah, I would agree. So the one I had recently, he was pretty effusive, the fetlock joint and the sheath. So that's why we prostrided him first and then Arthramid. And at 30 days, we rechecked him, and you could see the lesion on the radiographs. And I've been just thinking, like, what am I going to do if it's still there at 60 days? It doesn't come sound. And I'd like to hear what you think about this. And I was thinking, would like doing regional limb with stem cells, or maybe something like Renovo in those cases, help those subchondral lesions? I don't know the answer to that, but it just popped in my head. It's like, okay, they're going to make me try something. Because it's certainly like yours wasn't appropriate for a screw or anything. There's no
No,
way
it
to
was
get
too
to it.
proximal. Mm,
Yeah.
yeah.
So I don't know if that would work, but at least with mine, yeah, I think you've got to give them time for those subchondrals to go away. But it certainly also helped with the effusion, and his joint's nice and tight now, and his sheath's half the size it was, and he jogged sound yesterday, so I got
That's the
lucky.
best case scenario there.
Yeah, I got really lucky.
For
He
sure.
cooperated.
I think that's all the questions that's from my list that I'm seeing here. So unless anybody else has one quick one, it looks like we've answered them all. So thank you both.
All right.
Thank you.
Well, thank you all so much for joining us this evening. We are so grateful to our presenters, both Dr. Sarah Jeune and Dr. Ron Gaeta, who also serve as two of our advisory council members. And as you can see, they both have an extensive amount of knowledge and expertise in equine sports medicine. And we're so grateful that you took time to share your knowledge with us and share these cases with us. And so with that being said, we hope that you all will continue to consider utilizing Arthramid in your cases and starting to see the benefits of that. We're certainly gearing up for AAP coming up and have some exciting presentations that was discussed coming up in December. And so we hope that you all will attend, for those of you that are going to AAP, and will be part of that as we roll out some new research that's coming out and available. I'd also like for you all to keep an eye out on your email inboxes in the coming days. You will be receiving an email with a recording from this webinar, as well as your CE certificate in your inbox. If you do not receive that, please let us know, and we'll be happy to resend it to you as well. I'd also like for you all to mark your calendars for Thursday, November the 6th, which is our next scheduled webinar. It will actually be practical uses of 2.5% polyacrylamide from an equine surgeon's perspective. And we have our panelists will be Dr. Lisa Fortier, Dr. Kyla Ordvet, and Dr. Wayne McElraith. So thank you all very much for your time tonight, and we look forward to seeing you all soon.
Great. Thank you.
Thank you.
Thanks, guys.